One of the reasons why we monitor respiratory numbers is because we're looking at those values decreasing as the first signs of being a respiratory problem. Most times patients will not come in with respiratory symptoms or complaints of being short of breath or anything like that. They'll have other complaints, maybe morning headache, maybe uh, being lethargic throughout the day, or needing daytime naps when they never needed naps before, using multiple pillows, things like that, that are all triggers for us to think that there is some sort of respiratory problem, and then we get that backed up with the respiratory numbers. So when we see a decrease in the value of their forced vital capacity, or maybe their inspiratory or expiratory pressure, we're trying to bring on that respiratory equipment in the form of a BiPAP machine typically, and bring it on early, introduce it early, so that the patient can get used to the machine when they're not under respiratory distress. So they're not already complaining of feeling short of breath and needing a device. They have the opportunity to wear the device for 10, 15 minutes at a time, take it off, not feel like they have to have it to be able to breathe. It gives them time to get used to it, and we're being proactive in starting them on it so that they're very well used to it and are comfortable with it before we get to the point where we say you need to sleep with this 8-10 hours at night, that sort of thing. So that's why we're asking other sorts of questions that aren't necessarily shortness of breath symptoms, but yet trigger us to know that there is some sort of respiratory compromise going on well in advance, so that we can be proactive, get that BiPAP machine on, which then has obviously been shown to extend their life by 15 to 18 months if used the way it should be used. We have some patients that are very focused on numbers, and I try to steer them clear of that because a number doesn't always mean everything. However, we monitor those numbers for very specific reasons. Number one, there are certain guidelines that insurance companies tell us that they have to reach before equipment is paid for. But also, we're looking at things like a feeding tube, for instance. If a patient comes to us and says that they're interested in a feeding tube in the future, but that respiratory number is decreasing, then we know that they may have complications in surgery with coming off of anesthesia and a ventilator. So we want to make sure that they have the best chance of going into surgery for a feeding tube and coming off of that anesthesia and that ventilator with a routine procedure like that. So we're always going to be looking at those numbers and making sure that if they want a feeding tube, even if they're not to the point where they can't swallow, if the respiratory numbers are showing us that they may have a problem with coming off of anesthesia and coming off of the ventilator, we're going to put the feeding tube in proactively so that we don't have that problem in the future if those numbers would drop to the point where we may have a problem with getting them off of ventilation. Some patients choose not to be ventilated, and so we would not want to discourage them from getting a procedure just because of that. So we're watching those numbers to make sure. So the number that kind of the textbook will tell you is a forced vital capacity of 50%. If it's less than that, then we're really kind of not sure that a patient is going to come off of ventilation at that time. So that's the benchmark number that we're kind of looking for when patients are thinking about surgery or things like that. Way before the 50% though, we're looking at BiPAP therapy, cough assist therapy, suction, and those sorts of things. So patients should already have equipment on board if that number is getting lower, but the 50% range is when we're really considering any kind of surgeries that would need to be done requiring anesthesia.